Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach. And this is Dadvice TV Live, episode 320. That's 320 episodes of information to help you live better and live longer while you happen to have some kidney problems. Now, tonight, we've got your favorite co-host here, the author of the best book about kidney disease. The book that when I was diagnosed, life would have been so much easier if the doctor said, hey, you've got kidney disease. Don't go on the internet. There's a lot of wrong information out there. It's going to scare you. Check out this book. It's easy to read. It's going to tell you what matters, what you need to know, and it's going to set you up for a good path going forward. And that book is Learn the Facts About Kidney Disease, the book that all of you should read if you have not read it yet. And we have with us here the author of that book. And before I get to him, let me say hello to a few people that are here already in the audience. Hey, Debbie, great to have you here. Ray from over across the pond in the UK, great to have you here. We got Texas Grammy saying hello. Rita saying, hey, she's excited to be here because we're going to be talking about weight loss drugs that are great. That could be great for kidney patients. So she doesn't need to lose weight. Well, don't worry, Rita. I need to lose some for you. I'll do the work and help you there. Sandra says hi. Oh, that's great. Love the audience here and the engagement. So let me go ahead and bring on my co-host, the one, the only nephrologist, Dr. Stephen Rosansky. Hey, Doc, how you doing?
I'm good, James. Always good to see you. Always great to be on your show. And I will address the last comment about not needing to lose weight. We're going to be talking about many times the newer drugs that may have advantages for kidney patients beyond losing weight. I mean, the focus is on the weight issue tonight, but these drugs have benefits beyond losing weight, which you're going to learn. And where do you want to start? You want me to tell people who I am in case?
Yeah, let's do a quick introduction of you. And I've got to adjust your camera a little bit here. Doc and I were messing with the lighting and stuff, so I want to make sure he looks good here. Let's do a quick introduction about some of your credentials so that people know you are the real thing. Your science, your facts, your what really matters, not one of those fake websites pushing some fake cure and selling some bottle of something for $99 a month.
Well, I am a retired kidney specialist. I've taken care of thousands of kidney patients, worked over 40 years taking care of kidney patients. I am also a person who has what they call academic credentials. I've published over 100 papers. And even though I'm retired for a good while, I still review papers. I have had a high profile editorial recently came out. So I'm still in the game. I still try to stay up to date. And you will benefit from the information that I continue to learn. And we're going to talk about stuff that's hot off the press tonight. And yeah, I mean, one of the reasons why I wrote the book that James showed you is that my research, I seem to be having some pronunciation difficulties. My research on when to start dialysis was voted the #1 game changer in my field. And what I showed was that starting dialysis early is harmful. And way too many people, especially in the US and in many other countries in Europe, they started people on dialysis early without good reason. And it turns out that my work and other people's work showed that it's not such a great idea. So I got this information out to my colleagues, try to get it out as far as I can to patients. But I figured the best way to get it to patients is to write this book. And the book turned out to not only help people, I hope, avoid unnecessary dialysis, but also allay a lot of fears that people worry so much about having kidney disease when they have just insignificant lab values that don't really mean anything regarding developing kidney failure or needing dialysis. And that's one of the two of the big issues that I address in the book, in addition to other important things, all the way from what to do with very mild, what the kidneys are all about. And if you ever have to go on a dialysis or need a transplant, I go through that decision process for you. So we're going to dig in because there's a lot to talk about. And James loves to get me to answer questions, and I'll try to have some time.
Yep. So everyone, enter in your questions for the doc. And once we're done talking about today's main topic, he gets to as many of them as possible. So if you type them in now, you're at the top of the list.
Okay. These new drugs, and everybody has heard about these miracle weight loss drugs. There's hundreds of studies underway. They're called the GLP-1 drugs. They were originally just diabetes drugs. And the benefits of these drugs are really astounding. Not only do they help diabetics, and they help diabetics clearly, but they help you decrease your risk, and we'll get into this a lot tonight, of cardiovascular disease, the thing that James loves to talk about, the atherosclerotic cardiovascular disease, the hardening of the arteries that we all get with age that causes the strokes and the heart attacks and the heart failure and the bad things that are the commonest causes of death. Not only does it do that, it helps decrease fatty liver. Some of you may have heard of, which people worry about. Their liver enzymes go up, which can, in some cases, lead to liver failure, cirrhosis. They decrease your knee arthritis, probably related to weight and maybe independently of weight. And they help with addictive behaviors, James. Not just eating, smoking, drinking, gambling. I mean, these drugs are going to be tried for other things, and they may even help you with preserving your brain function, slowing your loss of cognitive function. The two biggies that are the two weight loss biggies are semaglutide, and a lot of people now have heard about Wegovy and Ozempic. They've almost become household terms. The type of drug that they are called GLP-1, and I'll tell you what that means in a minute. And those of you who are on the Wegovy or Ozempic, you started out at about 0.25 milligrams. That's the first dose for about a month, and up to about a half a milligram as the monthly dose. It's an injectable. And then the other weight loss drug out there on the market, the big one, is Zepbound or Mounjaro. This is a dual-acting drug. So you have the GLP-1, and I'm going to tell you what that means in a minute, and the GIP, that's the other action, GLP-1 and GIP. So right now we have drugs that are dual action, and there's many, many, many more coming down the pipe. And you're going to be inundated with these drugs.
Quick question for you, Doc.
Yeah.
Because I'm interested in these, and I haven't spoken to my doctor about them, but I've seen the commercials. They're everywhere here in the United States. They're injectable. How often does a person have to inject themselves? Is this a once a week type thing, a once a month, or daily?
Okay. It's basically once a week. It's once a week. Wait a minute.
Okay, good.
You know what? I'm blocking on it. It's once weekly. Yeah, the drug that has become generic is daily. Okay.
Ooh.
Yeah, and I'll get to it in a minute. So what are these drugs? You have GLP-1 and GIP. You don't want to know what GIP stands for. It's a long thing. These are normal hormones that are made in the gut. When we eat food, these hormones will stimulate the pancreas to lower the blood sugar by increasing insulin. And they only will lower the sugar and decrease insulin, decrease the sugar level by increasing the release of insulin by the pancreas if your sugars are high, which means less of a chance to get low sugars. They decrease glucagon, so they're called GLP-1 is a glucagon-like peptide. I don't think you want to know what GIP is. It's a way long name which nobody's going to remember,
I have
but it's
enough
similar.
problem with the Arthur blah 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 blah.
Glycogen is a storage product of sugar in the liver, and those of you who are diabetic may, especially older diabetics, may know that when your sugar was low, you had a glycogen hit, because glycogen could get your sugar back up real quickly by releasing glucose from the liver. So the drug will decrease, it'll increase insulin, it'll decrease glucagon. And here's some other things it does. It gets your stomach to slow down emptying, so you feel full longer. And it works on the brain. This is probably why it helps the addictive behaviors. They're trying to figure that out, but it clearly helps the appetite center of the brain. So it can decrease your hunger and get you to eat less calories. Now, the GIP for the dual receptor drug does similar stuff to the GLP-1, and it may work together with it by stabilizing your sugar levels, reduce your cravings, and make you feel full. And this is what you want to do. And just to tell you, by next 2 years, you're going to have a bunch of clinical trials that come out with new options, because these drugs are billion-dollar drugs, as you all know.
Mm-hmm.
So there's going to be a lot more of them out. What did we learn about these drugs? Well, first, we said, oh, these are great. They're diabetes drugs, just like the drug we talked about last month. Do you remember the type of drugs we talked about last month?
Was that SGLT2s?
Yay, James, you got it. Those are powerful drugs. And we've got a lot of research on it. Please listen to that talk. These drugs do similar stuff, but they don't have as much kidney research on them. And I'm going to talk to you today about what we know about kidney research on these GLP-1s. They, like the SGLT2s, help decrease your risk of death from heart attacks and strokes. Big thing. Most people with CKD are never going to get kidney failure. They're never going to go on dialysis, but they do have a higher risk of dying from heart disease or strokes. Big message that we've talked about over and over again. And so the GLP-1s, like the SGLT2s, the SGLT2s are the gliflozins, canagliflozins, empagliflozins. We got to get the vocabulary out there, just like we did
Yep.
with the ACEs and the ARBs, right?
Yeah, exactly.
Right? The ACEs, right? What are the ACEs? The
Okay,
prills.
they're the prill, and the
Prills.
arbs are the tans.
TANs, yeah. So we got to get the lingo out there. Everybody needs to be familiar with the lingo. So the GLP-1s work on blood vessels, blood pressure, and lipids. So that's why they help not just diabetes, but the cardiovascular disease. Let's talk about 3 trials tonight. The first was the SELECT trial, where they realized, hey, these drugs do more than just treat diabetes. What they did is they used the Ozempic Wegovy, and they had people that already were overweight, and they found out that they can decrease your risk of dying from one of those bad cardiovascular events by 20%. Now, that study was not designed to look at kidneys, but this is still important. You want to decrease your risk of cardiovascular event. Now, what they did show in that SELECT study is that GLP-1, the Wegovy, Ozempic, decreased the albuminuria, the albumin creatinine ratio. Remember, we talked about this over and over.
Mm-hmm.
You want your doctor, anyone with kidney disease, please be sure to get your doctor to check your urine protein. And the best way, the most popular way to do it is a urine sample sent to the lab to measure the albumin and the creatinine in the urine. And we talked about that a good bit. Now, then the next trial I mentioned briefly is something called the STEP trial. These have cool names. And the STEP trial was something for patients with an important condition. and I don't know how many of your viewers or even you, James, if he heard of it, we've mentioned it, is heart failure with preserved ejection fraction. Ring a bell at all?
Does
No.
not ring a bell. We have not spoken
Okay.
about that very much
Okay.
then.
Okay. So heart failure. A lot of you folks may have had a test for heart failure. It's called the ejection fraction, or the EF. And what does that mean? It means the heart, you have a compression of the heart called systole. And the ejection fraction is the blood that comes out of that left ventricle that pumps around the body. What percentage of the blood that goes into that left ventricle is squeezed out with a beat? That's the ejection fraction. And heart failure with preserved ejection fraction, these people have over 50% that they squeeze out with the beat. And normally, if you have heart failure, the old way to talk about it is you had to have 20 to 30% squeezed out. So really weak. But these people with heart failure with preserved ejection fraction, almost a third to a half of them have CKD, extremely common. And many of your viewers probably have heart failure with preserved ejection fraction. And a lot of doctors, even some doctors, aren't tuned into this. You would hope they all are, because they say, oh, that ejection fraction is normal. Doesn't mean you don't have heart failure. And there's ways to diagnose it, but I'm not going to get into too technical, but there is a simple way to diagnose it on that echocardiogram. A lot of you have had that thing where they wave something over your chest and they could take a look at your heart and see how it functions. And that drug, the GLP-1, I think it was also the Wegovy type drug, had remarkable benefits on heart failure symptoms: less shortness of breath, reduced heart failure hospitalizations, better physical function. Normally, this heart failure, just like heart failure with a weaker pump, weaker
Mm-hmm.
squeeze, when you don't squeeze out 50%, treated the same way. Diuretics, a drug like you're on, the spironolactone, and the SGLT2 drugs, good for the heart failure, really good for the heart failure. And we know already that the SGLT2 drugs will improve your survival if you've got heart failure, kidney disease, diabetes. They're great drugs, and slow decline of kidney function. And now we're looking at GLP-1s, the magic weight loss drugs, seem to have the same benefits, but more research is going to be coming out. And so these are important drugs besides trying to keep your kidneys from failing. Because remember, you want to decrease your risk of death from heart disease. I just
Mm-hmm.
had a cousin of mine who sent me a message, first cousin my age, diabetic, has about a GFR of around 30 to 40. And he asked me what to do. And I said, what are you on? And I said, you need to be on an SGLT2. He's already on metformin. You
Mm-hmm.
need to be on SGLT2. That's what I recommend if you can get it, if you're a diabetic, independently of whether you've got protein in the urine, which we'll discuss in a minute. So the first and only study so far on the use of these GLP-1s, these weight loss drugs for kidney patients, is called the FLOW study. They all have these cool names, right? The FLOW study. Now, before I talk about the FLOW study, I want to tell you something that's really interesting to me. Because I got a lot of type 1 diabetics I see in the free clinic. I still see patients in the free clinic. And I go, gee, why can't I give them these drugs, these GLP-1 drugs? They seem, well, let me tell you, it's not just the money. And we're going to get into money in a minute, because money is a big thing. And as I said last time, and I want to repeat this, you don't have to spend a lot of money on SGLT2 if you've got mild CKD, 3A, 45 to 60 GFR, no protein in the urine. Don't waste your money. especially if you're an older patient, because you're not at a high risk of either the cardiovascular disease or the kidney failure. But if you got a lot of protein in the urine, definitely consider it. Or if you got lower GFR, like somewhere around 20 to 30 or 20 to 50, 20 to 45, whatever, maybe you want to think about it to decrease your risk of dying. So the diabetics who are type 1, so I told you these drugs, what do? They help lower your sugar by stimulating insulin. If you're a type 1 diabetic, you don't produce insulin. You have to take insulin.
Mm-hmm.
Your pancreas is shot. What I also tell you that these drugs slow the emptying of your stomach, make you feel full. If you're a type 1 diabetic, that could be a problem you already have, and you could make it worse. It's called diabetic, long word, gastroparesis. The stomach doesn't empty good, and that could cause vomiting. So, so there are several reasons why these drugs aren't really so great when you think about it. And then the third thing is they decrease glucagon. Remember I told you that? The GLP-1s decrease the glucagon. And I told you what glucagon does. It helps the liver release sugar from glycogen. And diabetics who are type 1, a big problem is their sugars go all over the place. And when they get low, they need that glucagon. So not great for type 1. So why is it important that we study type 2 diabetics with CKD? Why is it important? Because as we said, anyone with CKD, the most likely problem you're going to have is not going on dialysis, especially if it's stage 3, which is 30 to 60, or certainly stage 3A, 45 to 60. But you have a higher risk of cardiovascular death. If you happen to be diabetic and you've got kidney disease, that risk goes up 3 times compared to if you're just diabetic. So there's a lot of risk for diabetics with kidney disease to get one of these bad cardiovascular outcomes. So that's why they study them. And again, you want to decrease that bad outcome with SGLT2 drugs that we talked about last time. So here's a study, great study, and you folks are going to really learn something, I hope. So they took people with GFRs, like a lot of your audience, 50 to 75, but they had to have at least a albumin to creatinine of 300, which would be 30 in Europe or other parts of the world.
Mm-hmm.
That's
That's significant. Yeah.
Real significant. You got it, James. Real significant. And they also took people with GFRs as low as 25 to 50, and they didn't have to have as much protein. They had to have it over 100 or over 10 outside the US. These are albumin to creatinine ratios. On average, these were people at high risk. The average albumin creatinine was 500. So these were people at risk for progression. So the two things that get you to have a higher risk of progression or dying of a cardiovascular cause will be the lower level of your GFR and the higher amount of protein in the urine. If your GFR is real high, 3A, and you don't have protein, those risks go down a lot, okay? Now, before they even put you in the study, you had to be on a maximum dose of what type of drug, James, which we talked about always. Before you do anything
An
else.
ACE or an ARB.
Yay, James, you got it.
Which are so common and affordable. Yay.
And it's been shown that they have benefits. They have cardiovascular benefits, and they've got kidney benefits to keep you from having to go on dialysis. No question. So go on the ones that work and then add these on. So you had to be on the maximum dose of that. Then you could add on the GLP-1. And these were almost all on insulin. So these were sick people. Over 3,500 patients. And they either took the drug weekly. They take it weekly, James. That was the question you asked. Not monthly, weekly. This is the Ozempic Wegovy is a weekly injection. 1 milligram dose, all right? And, or a placebo. And this is what you got to do. The things you people are reading about online, the things you hear people who put white coats on, they're not placebo-controlled trials. They're garbage. And they want to push stuff that has not been studied. This is the way you study. You have to, they're very expensive. It takes a lot of patience and you got to use placebo control. Okay. It was stopped a year early. Why?
Because the results were great.
You got it, James. You got it. You got it. That's it. Shoot those fireworks. The results were great, and the drugs were safe. Get this, James. The serious adverse events were a little bit higher in the placebo group.
That's fantastic. That's just
Right?
natural
Okay.
stuff.
So again, compare this to the stuff you folks are hearing about somebody trying to push you, essential amino acid keto equivalents and extremely low protein diets. Never really been studied well. Very dangerous. None of the studies did what this study did to put you on what you have to already be on, an ACE or an ARB, and then add the other thing, which would be low protein. So there's no evidence for that stuff. And this guy's going to give you anecdotal stuff and tell you to buy his product. That's nonsense. Don't waste your money. Okay. The primary outcome here was a major kidney event. So this is the first GLP-1 kidney study. What's a major kidney event? You go on dialysis, you get a transplant, your GFR goes below 15, you drop your GFR by 50%, stuff like that. And the people on the GLP-1 versus the placebo, 24% lower risk of one of those bad kidney outcomes. And this is in 3 years, okay? And about a 20% lower risk of overall death. Impressive. So they stopped.
Awesome.
So the stuff works. The stuff works. And again, I want to repeat this. If you've got significant protein in the urine, the drugs are probably worth considering after you tried your ACE, you tried your ARB, and I would say before you go to this one, the SGLT2s have more data on them. So I would go to that one, unless you're in the weight loss thing, which we're going to get to. And then here's another one to use to help slow. So you can add them. I'm not a believer in adding them all at once. I would add them sequentially. An ACE or an ARB, not both. Okay? Next, SGLT2, and then after that, the GLP-1. I'm not a big proponent of the new, mineral called finerenone. I think the thing that James is on, which is spironolactone, which is dirt cheap, is what I would consider if you're really having trouble with high protein in the urine and losing kidney function. Now, again, even if you're not having high protein in the urine, if you're diabetic, probably a good drug for your diabetes, just like your SGLT2, to decrease your cardiovascular death. And a lot of diabetics, their insurance will cover these drugs. Now we're going to dig into the obesity and CKD, which is what the main topic of tonight's talk. So is there a relationship between losing kidney function and being obese, James? Have you heard anything on that?
I do not believe there is a relationship, but being obese probably means you're less active. There's a lot of heart-related risk. That would be my concern.
Right. Well, it's not strong, but there is some associative data that weight loss can slow progression of kidney disease. I mean, it's not like we've got massive data, but there is some data to show that. We know that weight loss can help prevent the atherosclerotic cardiovascular disease, the hardening of the artery problems. There's also evidence that weight loss can decrease the protein in the urine. And as we know, if you can decrease the protein in the urine, you've got a good shot at slowing the decline of kidney function. We know for sure that if you lose weight, your sugar control is better. Diabetics get much better control if they can lose weight. And we know that weight loss does a lot for lowering your blood pressure. Another good reason to lose weight if you're a kidney patient, especially if you're stage 4 or 5, is that you're not going to get on a kidney transplant list if you're too heavy. Most transplant centers have a weight cutoff. So you may want to need to lose weight for that. And of course, and all of us, lower weight may improve the quality of your life, and it may improve your mood, and it obviously has some psychological benefits. There are some downsides because people that lose weight, we know that if you lose weight with one of the things that preceded these new drugs, and if you use lifestyle things, calorie restriction and so forth, diet and exercise, the usual thing, only how many can maintain the loss of weight, James?
It's got to be so small.
But it's about 1 in 4. Some people say even less.
Yeah.
So, and the thing that I would say is if you're going to go on any serious weight loss program, or even if you go for one of these drugs, the weight loss drugs, you got to try to combine it with lifestyle. And if you can get yourself in the habit of exercising every day for 30 minutes, you can definitely have a good shot of keeping the weight off. But it's a
Yeah,
big
that right
commitment.
there, I was doing so good at that for a while, and was just dropping the weight as as if it was like anything. It was just coming off every time I got on the scale. But then I started allowing myself to skip exercise, and all of a sudden it feels so hard to get back into exercising.
Listen, I get it, and I go to the gym every day, and there aren't a lot of Steve Rosanskis going to the gym every day. There's a core group, and I get it's not for everybody, and that's why these drugs help. Okay, so what I'm going to talk about is what the international kidney organizations have recommended for weight loss for kidney patients. Right? They say, what should you do? First thing is lifestyle. Lifestyle. Jen talks about this, I'm sure, many times. I've talked about it on other shows. You know what we're going to say. Whole foods. Stay away from the packaged foods. Stay away from the ultra processed foods, which means things that you don't have to chew very much, things that you get in packages. Try to stay with
Things that
real
come through a
food.
drive-through window.
Yeah, stay with real foods, stay with things that are mostly plant-based, even with kidney disease, as we've said, even with more advanced kidney disease. Don't worry about high potassium unless your doctor says you got it. If you've got high potassium, then you have to adjust. But a lot of you people, even with advanced kidney disease, may not have to worry about it. Portion control. Mindfulness. Think about what you're doing. Don't just eat out of anxiety. And that's what a lot of us do. Eat foods you have to chew a lot. The processed foods just go down and watch those snacks. Watch the packages. Try to get rid of the packaged stuff. And physical activity most days. That's what lifestyle means. If you can do up to 30 minutes, take a walk. That may be good enough. Try to get sleep, because when you don't get sleep, you eat a lot more. Creates anxiety. It gets you to eat, and whatever you can do to decrease your stress. Stress will get you to eat a lot more, no question about it. So you need to work on all of these things. That's what the lifestyle package is. It's serious, it's hard, and it often fails. If it fails, the experts are saying that's when you think about the GLP-1s. All right. These drugs, the weight loss drugs. So the three are the Victoza, which was the first one out there as a diabetes drug. I used to use it in the free clinic. I guess the detail reps gave it away. And it was an injectable daily. It's kind of crazy. I mean, it's kind of pointless, but, it did have some benefit for your blood sugar. But the drug, which is generic, and cheaper than some of the other GLP-1s, is called Saxenda. Saxenda, okay. And Saxenda, it didn't have great results in terms of the weight loss. After a year, 60% lost 5% of their weight. Not impressive. As compared to the Wegovy Ozempic, about 15% impressive. You lose about 5 to 10% in the first 3 to 6 months, and the rest by 18 months. So it takes time. And then the double acting thing, the GIP, and the GLP-1, which is called Mounjaro and Zepbound. Some of these people lose 15 to 20%, maybe a little bit more, over a year and a half,
Wow.
and maybe losing 1 to 3 pounds per week. Again, these are weekly injected, starting at the lowest dose and gradually increasing it. Now, like everything else, there's no free lunch. The common adverse effects are GI, but they're usually mild. Some people have it moderate. You got about 20% get nausea, and about 15% will have diarrhea. Okay, and vomiting, 5 to 10% will have vomiting. So how do you decrease these side effects? I mean, not without side effects. You want to eat small meals and eat them slowly. You don't want to eat high calorie meals. You don't want to eat high fat meals.
Mm-hmm.
You want to have small portions. You want to eat slowly, at least 20 minutes. We eat very, very fast
Yeah.
to eat your meal. And you don't want to lie down after eating. Okay, no lying down. So some of these things that you do can help relieve the symptoms from the GLP-1. I don't treat people with it, but what the recommendation is, if you're having symptoms, your doctor may want to decrease the dose until you can tolerate it. Now, be aware that if you're getting persistent abdominal pain or vomiting, you could be having a serious side effect. And that could be pancreatitis, which potentially can be life-threatening, or gallbladder trouble. And these are not common. Maybe 1 in 20 people on these drugs will get it. You know, on the Wegovy drug, on the dual drug, the Mounjaro, Zepbound, a little higher. I'm sorry, 1 in 20 on the dual action drug, so it's a little more common, versus 3 out of 100 with the Wegovy. And the dual action drug is a more powerful drug, so you
Mm-hmm.
and we could get more bang for your buck, but you may get more side effects. Okay.
Now, you mentioned
Yeah.
gallbladder. If you're someone like me, I had my gallbladder removed.
Yeah.
Would I avoid
Yeah. Yeah.
those
Yeah.
medications, or do
Yeah.
I
Yeah.
just not worry about it?
Well, no. You don't have to avoid them. I mean, and these are not common side effects, but you may get symptoms that may or may not even be connected to the drug. But since these drugs are so widely used, there's going to be a lot of stuff reported that
Mm-hmm.
may or may not be directly connected. The one that is probably directly connected, which is most concerning, is pancreatitis. And those people have severe abdominal pain and vomiting, and they're real sick, and they know it. And that could be life-threatening. But again, it's rare. The other things to consider is it's like any other diabetic type drug, is low sugar. And especially as you're losing weight, you may likely need less insulin
Yeah, hey,
as you
that's a
lose
good
weight.
thing.
So, which is a good thing. So you can probably drop down your insulin dose. And then the other thing that happens as you lose weight is that you probably going to have better blood pressure control. So you may be able to tone down your blood pressure drugs, okay? And if you remember, we talked about the SGLT2 drugs last time. Also, you may need less blood pressure drugs because what you're doing is you're getting rid of some of your body volume because you're peeing out sugar. Those
Mm-hmm.
drugs, the SGLT, get you to pee out sugar in your urine. And also with a better diet, you may actually eat less salt, and so you may need less blood pressure medicine. Let's finish up. Talk about cost, which is an enormous one, right?
Mm-hmm.
So I was hoping that these drugs were going to become generic, and I looked up and I said, wow, that one drug that I mentioned, it's called liraglutide or Victoza, or the one that's used for weight loss is Saxenda, Saxenda. not an impressive weight loss drug, and it's daily injection. That's a lot. That's a lot. Um, and the Wegovy, Ozempic, you know when they're going to become generic?
It's going to be forever, isn't it?
2033.
Oh,
So we got
almost a
almost 10
decade.
years. Almost 10 years. Okay. And probably longer for the dual acting one, the Monjaro. And the other ones that are coming down the pipe will be even longer. And these are billion-dollar drugs. The good news is you folks can get online. My son-in-law did that. I think he gets his from Canada. And instead of spending $1,000 a month, you can decrease the cost between $250 to $500 a month, which is much more reasonable. So do your research. There are other options besides paying retail. And if you're going to do it, look for and there's a lot of reviews about the best places to get discounted weight loss drugs, and I'll let you folks get into that yourselves, and I'll try to answer some questions.
All right, Doc, we have tons and tons of questions in here. And we had lots of great comments talking about how much people love your book. Some people are even reading it right now. We've had Rosa here who's working on losing weight, went from 230 to 180. Congratulations. That is fantastic. So I'll let you start looking through the questions, Doc. We've got a good system here, and I'll pop them up on the screen as you find them.
Okay, let me. All right. Um, so, um, the best way to eat. Does it tell you the best way to eat?
Oh, it's talking about
Um,
your book.
oh. I honestly, yeah, I discussed that some, and if you look at some of my earlier Dadvice talks, I spend a lot of time on some of the talks talking about low carb diets, talking about all the various diets that are out there, and basically, I am not a fan of the keto diets. I don't think they make sense. And especially if you're diabetic, you could be in trouble with ketosis. um, I think a balanced, real food, plant-based diet is your best bet. and and obsessing over, what you eat, I mean, it's probably not worth the effort. What is most important is to have small meals, regular meals, and try to avoid the packaged foods as much as possible and eat slowly. Those are the most important things. Um, let's see what we got here. Um, Beverly wants to know, how can I lower creatine? I don't know if she means creatinine. James, I'll let you take that one.
All right. Creatinine is not the thing to worry about. It is a natural byproduct of muscle. Don't focus on lowering creatinine. If you want to focus on lowering things, get your blood pressure into a healthy range. If you have protein in your urine, work with your doctor to reduce that. But creatinine is the wrong thing. We think when we get diagnosed, it's the problem. It's not. It is a cheap and easy way to estimate your kidney function. And here's something to think about. If you were in an accident and your legs were amputated, your creatinine would go down because you'd have less muscle mass, but it isn't going to help your kidneys. And now you're going to have to use a more expensive test to estimate your kidney function. So don't worry about chasing your creatinine number. Focus on things like blood pressure, staying active, living a heart healthy lifestyle, reducing protein in your urine. That's my advice.
Sugar Ray wants to know, at what CKD stage would you start peritoneal dialysis? Okay. Anyone who has been talking to their doctor about starting dialysis, please read my book, because there are far too many doctors that are going to want to start you on dialysis at high levels of kidney function. The earliest time to start dialysis is so-called stage 5, which is less than 15 eGFR. And you can be a lot less than 15 for a while and still not have to go on dialysis.
Mm-hmm.
And the time you have to go on dialysis has been agreed by all of my colleagues that are in the same field and have done the research, is when you can't manage your kidney symptoms without a kidney machine. And that often doesn't happen until you're closer to 5 to 10, and not 15, and certainly not over 15. And there are some people that advocate starting early on peritoneal dialysis. And that's a complicated issue because you got to put a tube in your belly. I am not a fan of that. I don't think you should start any earlier than you absolutely have to. That would be my advice. Are these drugs very expensive, Beverly? Unfortunately, they are. They are. So look up the various reviews on the sources of getting discounted GLP-1 drugs. There's a lot out there. Rosa has a GFR of 26. Need to come up if I can. Okay. First of all, Rosa, GFR of 26 is not necessarily the absolute number. It could be anywhere between, 22 to 28 to 30. The big thing, as opposed to any EGFR number, is what, James?
Oops, sorry, I missed your question because I'm pulling up some more info about her. Just to let you know, she's 75, no protein in the urine. Now, what was
Rosa
your
is
question?
okay. As opposed to one GFR level, what is more important than one GFR
Oh,
level?
the trend over time, because your GFR is like the waves in the ocean; they go up and down.
Right. And Rosa, if you are in the 70s and your GFR is 26, and you don't have protein in the urine, my question is, are you one of these people that also has a weak heart? Do you have heart failure? And what happens for a lot of people is they have GFRs that go down to the 10-15 range, and they don't go on dialysis because of the kidney failure per se, it's because of heart failure. But if you got a GFR of 26 and no heart failure and you're not symptomatic, don't get your doctor to be pushing you on dialysis early or preparing you for dialysis early. And now, whether or not the GFR can improve, it's not likely, especially if there's not protein in the urine, especially if it's been like that for a long time. Is that the same patient, or is this
Yep,
someone
same
else?
patient. Yep.
Um, oh, this is the patient who lost weight?
Yeah, she lost weight, went from
Oh,
230 to 180, but her
oh,
blood pressure runs 130 over
that's
60.
that's all good. You're doing
Yep.
all the right things, and keep up the good work, and hopefully your GFR will stabilize. The only and I think you're doing everything right. Okay.
And her A1C
Um,
is only 5. That's fantastic.
well, that's normal, and so she's not diabetic. Yeah,
Yep.
that's not. Those don't need to be treated for that. And again, uh, we've talked about older folks being treated for diabetes. I'm much more concerned with you getting hypoglycemic, which is very common as we get older, and let your sugar run a bit high than to let it go too low. Um, and Yeah, if Michael's A1C is consistent below 6, don't allow it to get to be too low. Don't let your sugar get to be too low. Someone had a transplant, doing well, that's great. And someone's got a spike in A1C, losing weight, that will help. And Daughter-in-law has, among various side effects, are terrible. Look, Beverly,
Mhm.
everybody talks about these drugs as if they're a free lunch. There's no free lunch, and you know the MON drug, the dual drug, is probably a little harder on the system than the one that's just GLP-1, not the GLP-1, the GIP, which is the dual drug. Might be better off trying that drug at a low dose. And again, I have not been treating people with these drugs, so I can't tell you. But what I've read is that your doctor wants to use the lowest dose possible of any of these drugs. Okay. Ejection fraction 55, Sugar Ray. Maximum 70. Well, anyway, 55 is fine as long as you're not symptomatic. You don't have heart failure. A1C is 575. That's not diabetes. No protein in the urine. That's Rosa. We talked about
Yep,
that.
that's Rosa. Hey, I got one for you, Doc. It
Right.
just came in near the bottom. So Carlos says his mom is 74. Her GFR is stable, keeps coming out at 38. She has no significant protein in her urine and no blood. He wants to know, should he be concerned?
Well, it's not a question. Yeah. Look, she's again. If you are an older person with that level of GFR, it's more likely that you're going to have to worry about having a heart problem, a heart attack, or a stroke, or one of those causes of death. So, if you can get the SGLT2 drug, I would recommend it, even without having protein in the urine, because of the benefits on cardiovascular mortality. I think the benefits are real, and that's something that I would recommend, just like I did for my cousin. Uh, and, uh, and like I said, more people are going to die, not on dialysis, but with one of the cardiovascular reasons. Um, how do you know if you have high blood pressure causing kidney issues? Okay, well, Doug, you bring up a good question. It's the old chicken and egg question.
Mhm.
And it works both ways. Kidney disease will cause high blood pressure, and high blood pressure can cause loss of kidney function. And of the things to do that are cheap and that have been shown to be of great benefit is controlling your blood pressure to goal to keep your kidney uh, function from going down too quickly, to slow the decline. And the goal blood pressure, if you can tolerate it, is around 120 or less. And there's several talks that we've given about treating high blood pressure and the best drugs to use to treat your blood pressure. Um, Roberto has a 100 over 60 blood pressure, CKD3B, uh, losartan on 50 milligrams. Well,
No, he's on
Roberto,
100. Wait, he was on
yeah,
100, but now they cut
yeah.
it to 50. Yeah.
Roberto, at a systolic of 100, I'm not sure what your age is, but there is a debate there. I think that unless you have a lot of protein in your, if you've got um, uh, CKD3B, which is EGFR of what's 3B, James? Remember?
The 3B is 30 to 45.
Exactly. Okay. So you've got a GFR of 30 to 45. I think that if you don't have protein in the urine, 100 is too low for my taste. On the other hand, uh, depending on your age and your current cardiovascular risk, you still may be a candidate for the SGLT2, which I would still consider at that level of kidney function, which can lower blood pressure, but not as much as the losartan. I think at 100 over 60, that's a bit low for my taste. Um,
You're
Beverly's
kind of
asking.
sinking off the screen, Doc.
Oh, okay. Okay. I'll get up here.
Soon
Okay.
you'll just be eyeballs.
Okay. I'm not going down here. All right. Is a diuretic bad for the kidneys? Well, I mean, taking a diuretic, if you're already dehydrated, is very bad for the kidneys. That'll make your kidney function worse. On the other hand, if you're a hypertensive patient, a low dose of a diuretic can benefit your blood pressure regimen. Most blood pressure regimens will be better at lowering blood pressure if they have a low dose of a diuretic included. But if you are already dehydrated, your kidneys will not be happy if you take a diuretic. It makes it worse.
No, and I have a diuretic in my list of meds that I take.
Yeah, I mean, most people that are hypertensive are on diuretics. Shine has a GFR 32, the BP 160/90, losartan 100, BP 110. Well, okay, I mean, look, the 160/90 might have been a white coat blood pressure.
Mm-hmm.
Because your blood pressure can be higher in the doctor's office. And again, I tell patients to monitor their blood pressure. Don't go crazy over it because people get too anxious with their blood pressure, which you can raise your blood pressure even at home without the white coat phenomenon being in the doctor's office. But, Shiny, if you tolerate the 110, not causing any side effects, especially if you've got protein in the urine, I would be okay with that. I'd be fine with that. But again, it depends on your age. I mean, an older person, letting the blood pressure get that low can start having effect on getting blood flow to your brain. So I'd be a little more concerned than I
All
would
right,
be.
we're almost to the top of the hour, Doc. Let's do one more question.
Okay. It's 5.6 is not pre-diabetic. I mean, basically, pre-diabetes, it would be on your fasting sugar, and again, if you're an older person,
Oh, there
oops.
goes your phone.
Okay, what did I do? I just watched. Oh, that was okay. All right, am I going to get you back? Well,
You're still with us. Oh, we lost the Doc. All right. That's okay. Hold on. Here he comes back. Let me bring him back on so he can say goodbye.
okay. Well, sorry about.
Oops. There you are. Well, we're at the top of the hour anyway, Doc.
Okay, well, that was my doctor daughter.
Okay. And your screen for some reason is blinking. I think it's just because of how I got you also twice on this side. I'm not sure how, but thank you so much for joining us, Doc. Thank you, everybody out there. Let me remind you of Doc's book. It's a fantastic book, super duper easy to read and understand. It lets you know what you need to focus on so you're not worried or chasing the wrong thing, like trying to get your creatinine down or anything like that. It is called Learn the Facts About Kidney Disease. You can get it at Amazon and get it any mom and pop bookstore. They can order it. And it's great to support those local mom and pop stores, especially as we get into the end of the year. They would love to get your business. All right, everybody, let me bring Doc back here on the screen. It's still flashing over here. It's like you're in a one of those rooms where there's a strobe light, and now it went out completely. All right, thank you, everybody. He's coming back again. Oh, this is hilarious. All right, you're back again, but we can't hear you, Doc. Hey, we got it all good. All right, bye, Doc. Bye, all of you. I'll see you all in the next video. Have a wonderful holiday. Next week is Thanksgiving. We'll see you all next month in December. Bye, everybody.